Shawty fire burning on the dance floor. Whoa.
Burns are classified in terms of etiology, depth of tissue damage, total body surface area involved, and severity. A burn injury can result when tissues of the body are damaged by a heat source. These sources may be thermal, electrical, chemical, or result of radiation. The first type of classification we're going to talk about is according to the depth of tissue damage. This is superficial, partial thickness, or full thickness. Superficial burns occur when there's minimal damage to the epidermis. The wound is dry, there's no blisters, it's pink or red, and it blanches easily. The area is hypersensitive, and the healing occurs within 3 to 7 days. For superficial partial thickness, the entire epidermis, and there's minimal damage to the dermis. Wound characteristics are that it blisters and may be open or closed in weeping. It'll be pink or red and mild edema and blanches easily. It'll be hypersensitive and healing occurs in 7 to 14 days. On the next slide, you can see that the first picture is of a superficial burn, and that would occur from something such as a sunburn. The second one is a superficial partial thickness burn, and that can occur from hitting your hand on a curling iron or touching a hot oven by accident, but then removing it pretty fast. The first picture is before debridement, and then the second picture is after debridement of the blisters. With burn depth of deep partial thickness, the tissue involved is the entire epidermis and deeper layers of the dermis. The wound may be characterized by blisters that may be closed or open. It'll have a waxy appearance, be cherry red, molted, or pale in the center. There will be edema, and there's going to be sluggish or no blanching. For pain assessment, it'll be hypersensitive around the wound edges, but it may be sensitive to pressure only in the center. Healing may take 3 to 6 weeks and leave some scarring, and it may need to be grafted. For full thickness burns, the tissue involvement includes the entire epidermis and dermis that may have been destroyed. It may involve subcutaneous fat, muscle, and or bone. The wound itself is going to be dry, leathery, pale, white, brown, tan, black, or charred. There's going to be no blanching, and it may be contracted if muscle is involved. For pain assessment, there's going to be no pain in the center of the wound, but it may be sensitive to pressure. Healing, it will not heal without grafting. In the next slide, you can see pictures of a deep partial thickness burn where there's blisters and it's been debrided. And the second picture is going to be full thickness burns.
For burn etiology, thermal burns result from flash, scald, or contact with hot objects or flames, such as a house or car fire. Contact burns considered thermal and usually the result of cooking or heating incidents. Scald injuries from abuse or touching a hot object usually happen to kids. 2 factors to determine depth of injury: the temperature of the skin when that it's heated to, and duration. Electrical burns make up 4% of burns and usually occur from work-related accidents. The epidermis is the body's best insulation, but breached electricity tends to run along the bone, damaging overlying muscle, nerves, and vessels. Deep muscle injury may happen even if the skin or the superficial muscle looks normal. Should look for contact points over the entire body, sometimes hidden on the scalp. Place patient in cervical collar until cleared. Initiate cardiac monitoring for 24 to 48 hours. Fluid resuscitation, neurological assessment, renal management, and peripheral circulation maintenance. Chemical burns make up 3% of burns, and there are 3 subclasses, which are acids, alkalines, and organic compounds. Alkali burns usually penetrate deepest, causing liquefaction, necrosis under underlying tissue. Organic compounds, such as gasoline, are systemically absorbed into the body, causing renal and hepatic damage. Examples are gasoline, lime, hydrofluoric acid, and bleach. Radiation burns are the least common type. Their severity dependent by type of radiation, dose, and time exposed. Usually happen during industrial use of ionizing radiation, nuclear accidents, or therapeutic radiation treatments. Sunburn is the most common radiation burn in healthcare settings that's caused by ultraviolet radiation.
Next, we're going to talk about the systemic effects of burns, starting off with the respiratory effects. Inhalation injuries are present in 20 to 50% of patients admitted to burn centers, and 60 to 70% of these patients die in these burn centers. Inhalation injuries should always be considered when the patient was injured or trapped within an enclosed space, such as a house, a car, or there are burn injuries of the face, neck, or chest. There are 3 main respiratory complications to be considered when managing an inhalation injury, and they include carbon monoxide poisoning, injury above the glottis, and injury below the glottis. Patients with an inhalation injury may present with facial burns, singed nasal and facial hairs, carbon in their sputum, redness of the oral pharynx, inability to swallow, and tachypnea. Patients that present with any manifestations of respiratory distress should be considered for endotracheal intubation. Moving on to the cardiovascular effects. Initially, the greatest risks to a burn patient is burn shock, which is caused by a massive fluid shift. This process causes an increase in the viscosity of the blood, which is why many patients will present with an elevated hematocrit. Fluid leakage will occur within the first 8 to 36 hours after the injury, with the maximum shift at 24 hours. Without proper fluid resuscitation, the patient will begin to decompensate, resulting in multi-system organ failure and possibly death. Moving on to fluids and electrolyte systemic effects. Initially, hyperkalemia may result because of the release of potassium from damaged cells into the vascular space. As the fluid shift continues, potassium and sodium begin to leak out of the intravascular spaces, and hypokalemia and hyponatremia may result. You must account for the evaporative fluid loss that may occur through the burn wound and may be up to 5 liters per day. Renal effects are the renal function may be impaired due to the decrease in circulating blood volume, causing a decrease in renal perfusion. When fluid resuscitation and resulting blood flow are inadequate, myoglobin and hemoglobin have the potential to occlude the renal tubules, causing acute tubular necrosis, which is most commonly seen in electrical injuries. Moving on to GI effects. The patient with a burn injury often has complications of the GI system secondary to a decrease in both nutrient absorption and GI motility. A NG tube is placed in patients with large burns for both long-term feeding access and to relieve initial gastric distension, nausea, and vomiting. Patients requiring massive fluid resuscitation are at a risk for abdominal compartment syndrome secondary to massive resuscitation volumes. Moving on to the metabolic effects. Because of the array of physiological alterations in the body, a patient may be in a constant hypermetabolic state for up to 1 year post-injury. Most burn patients need additional nutritional support to ensure wound healing is not impaired. Body heat is lost through the open wounds, which is why it is essential to maintain a high ambient temperature within the patient's room or the operating room. And next is the immunological effects of the body. The body is at high risk for infection and sepsis because of the loss of the protective function of the skin, altered immunological defenses, and the presence of open burn wounds. Patients are in a constant state of systemic inflammatory response syndrome. The term systemic inflammatory response syndrome relates to the exaggerated inflammatory response that occurs in the body after injury and may precede the development of sepsis, and all burn patients exhibit some form of systemic inflammatory response syndrome regardless of whether or not sepsis ensues. And finally, moving on to sepsis, which could be one of the final systemic effects of burns. If the patient survives the first 24 hours after the initial burn injury, sepsis is usually the leading cause of death. Infection control is one of the highest priorities in a burn patient. Burn centers employ multiple infection control strategies and techniques, including contact precautions for all patient interactions, disposable equipment including blood pressure cuffs, stethoscopes, ECG leads, and antibiotic-coated urinary and central line catheters. Moving on to the burn changes when we're talking about anatomical changes versus functional changes. Anatomical changes, mostly the full thickness burns, will result in the most significant anatomical skin changes. Grafted skin can become severely scarred, causing normal movement and appearance to be impaired. The zone of coagulation is considered the area that had the most contact with the heat source and is the location of the most severe damage. and the zone of stasis is the area that immediately surrounds the zone of coagulation and is characterized by damaged cells and impaired circulation. Improper resuscitation or under-resuscitation may cause the burn to become deeper because of the limited blood flow, causing the zone of stasis to convert into the zone of coagulation. The outermost area is termed the zone of hyperemia and is generally an area of increased blood flow in an effort to bring key nutrients for tissue recovery. This area usually recovers spontaneously within 1 to 2 weeks. The full extent of damage may not be evident for 24 to 72 hours post-injury, as burns may take that long to declare the true depth of their injury. Moving on to functional changes, the location of the burn injury determines the functional changes that may result. According to the American Burn Association, referral criteria to a burn center involve injuries to specific area of the body, including the face, hands, feet, genitalia, and perineum, and burns over major joints. Burns in these locations involve functional areas of the body and may require specialized and highly skilled intervention in order to restore optimal function. Survivors of large burns often require multiple and sometimes lifelong plastic and reconstructive surgical procedures in order to maintain proper function and range of motion.
Now we're going to talk about the therapeutic management and nursing care of burn injuries. There are 3 phases of burns. The first one is emergent phase, the second one is the intermediate phase, and the third one is the rehabilitative phase. First, I'm going to talk about the emergent phase. With airway maintenance, non-rebreather masks are used on all patients with 100% oxygen. Some indications for intubation may include facial burns, changes in voice, carbon in the sputum, or fire injury in an enclosed space. Fluid resuscitation involves IV access as soon as possible, and some patients may require central venous catheters for large amounts of fluids. Lactated ringers are used most often, and IV resuscitation is started in all adults with 20% total body surface area of burns, and for children and older adults, fluid resuscitation is started at 10% total body surface area of burns. For the nursing care of the emergent phase of burns, it is important to assess airway management, fluid volume status, temperature control, pain management, burn size and depth, and to also provide humidified oxygen if necessary, estimate the total body surface area burned, place 2 large IVs, and institute warming measures while covering the wounds. To monitor the fluid status appropriately, an indwelling urinary catheter is usually used for close monitoring of urinary output. Diuretics are not indicated. If urine output decreases, fluid administration is increased. Other parameters for monitoring during fluid resuscitation includes heart rate, blood pressure, central venous pressure, serum chemistries, hemoglobin, and hematocrit. Like mentioned in the last slide, it is important to note that some patients might be sensitive to fluids and should be closely monitored for fluid volume overload. Some diagnostic studies include complete blood counts, serum glucose, creatinine, BUN, PT, APTT, INR, CMP, ABGs, ECG, chest x-ray, and toxicology screening. Some inhalation injuries require carboxyhemoglobin level and a bronchoscopy for definitive diagnosis. And for electrical injuries, it's important to get a baseline ECG, a troponin level, and CK-MB levels. Common fluid and electrolyte changes in the emergent phase include generalized dehydration, reduction in blood volume, decreased urinary output, hyperkalemia, hyponatremia, metabolic acidosis, and elevated hematocrit. One of our top priorities during the emergent phase is to prevent hypothermia, as skin is our primary insulation. So it's important to keep the patient covered at all times and to closely monitor their temperature. And the room temperature might be significantly increased. Wound care is usually not the priority during this initial phase due to other more life-threatening issues that become the priorities. In the meantime, burns are covered with clean, dry blankets and sometimes will last several hours until the patient is stabilized. For pain management, IV narcotics are usually administered, including morphine sulfate, fentanyl, or Dilaudid. The IM route is usually avoided because there may be impaired absorption due to edema or decreased peripheral perfusion. Some other medications that may be administered include anticoagulation therapies, nutritional support, GI motility, anxiety, and depression. GI motility, anxiety, and depression are the focuses in addition to pain management, as well as antipsychotics and anti-anxiety meds. The second phase of burns are the intermediate phase. This phase usually begins 48 to 72 hours after the initial injury occurs and after the patient is stabilized. As nurses, it is important to focus on wound healing and closure, pain management, ensuring optimal nutrition, and prevention of infection. The three different kinds of pain that are associated with burns include the initial pain from the actual burn itself, called background pain, and then there's the pain from ADLs such as walking, which is called breakthrough pain, and then there's the pain associated with wound care and physical therapy, called procedural pain. Like stated in the last slide, IV narcotics are the drug of choice for pain. However, it is important to differentiate between pain and anxiety because both are treated differently. Prevention of infection. Hydrotherapy uses water to clean the wound and removes residual topical agents and necrotic tissue. Infection is the most common cause of death after emergent phase, resulting in sepsis and multi-system organ failure, making prevention of infection such a huge aspect of the intermediate phase nursing care. It is important to assess weight, nutrition, white blood cells, wounds for signs of healing and infection, pain, and participation in ADLs. It is also important to pre-medicate the patient before wound changes, encourage intake, daily wound care, and assist the patient with ADLs as needed. The third and last phase of the burn process is the rehabilitative phase. This stage may last for several years and consists of physical and emotional challenges. Some complications include contractures, which are permanent tightening of the skin resulting in limited mobility. And in children, this can also prevent growth. Another complication is scarring. Any area that has been grafted will have some level of scarring, and this can be emotionally challenging for the patient. It's important to assess the patient's pain, range of motion, compliance with regimen, and readiness for societal integration. It is important to encourage the patient to perform ADLs and include psychology in the patient's treatment plan and provide community resources for discharge.
Special nursing considerations for inhalation injuries can exist in the presence of missing of a skin burn. Monitor for less obvious indicators of inhalation injury, including change of voice or hoarseness, anxiety, and/or confusion. Record if burns happened inside or outside, since increased risk if they were inside. Incubate early for any questionable airway patency. Emergency trach tray should always be maintained at the bedside. Always use umbilical twill to secure the endotracheal tube because adhesive tape doesn't stick well to burns. For electrical injuries, cardiac monitoring for 24 to 48 hours for anyone with extreme burn size, cardiac arrest, or dysrhythmias. Obtain a baseline ECG. Fluid resuscitation calculated by using the Parkland formula. Muscle damage can be seen by a red or tea-colored urine. First 48 hours, check all pulses to assess for compartment syndrome on hourly basis. Report any change to provider, even if it's only diminished. For chemical injuries, early recognition is critical. Then initiate treatment is removing saturated clothes, brushing off the skin if chemical is a powder, and continuous irrigation with water. Irrigation can cease when patient's pain is decreased, patient's temperature can't be tolerated during irrigation, or a transfer to the burn center. Tar and asphalt burns should be immediately cooled rather than removing.
During the emergent phase, the teaching includes explaining all procedures to the patient and family in clear and simple terms, which can help alleviate fear and anxiety in the patient. Teaching about the importance of maintaining a warm environment to prevent hypothermia, and teaching risk factors that increase chances of infection, as well as infection precautions such as gloves, gowns, and hand washing. In the intermediate phase, it's important to teach that the patient should request pain medication when needed and not to delay until the pain is intense, because if the pain becomes intolerable, it can be difficult to bring it back down. Provide information to the patient and family about natural progression of burns, wounds, grafts, and/or sites. This can help reduce misconceptions and anxiety related to the recovery and surgery. Providing a rehabilitation plan and discussing the importance of doing ADLs. That's really important because it includes self-encouragement and helps prevent complications associated with decreased mobility and provides a sense of control. It's important to also educate about nutrition and make a diet plan because nutrition is essential for wound healing, performance of ADLs, and the rehabilitation regimen. As you can see, the emergent phase is more about relieving anxiety and explaining what's about to happen and stabilizing the patient, whereas intermediate phase is about actually treating the patient and planning for the rehabilitative phase. The rehabilitative phase involves teaching about life after they leave the hospital, and that includes the importance of applying the pressure garments or the face masks as ordered, importance of protecting the burn with sunscreen from the sunlight, and preventing hyperthermia.
The title of the article we selected was A Prospective Observation on Nutrition Support in Adult Patients with Severe Burns. This article used level 3 evidence and was a controlled trial without randomization to compare patients with severe burns receiving parenteral nutrition versus those affected patients using enteral nutrition. For this article, we developed a PICO question. The population of the study was patients with severe burn injuries that covered over 50% of the total body surface area. The intervention under evaluation was the use of enteral nutrition. The comparison group was patients with severe burn injuries receiving parenteral nutrition. The outcomes were feeding tolerance, energy supplement, and the transition to oral nutrition. According to this study, patients receiving enteral nutrition had easier, more and faster transitions to oral nutrition than those receiving parenteral nutrition. However, the use of enteral nutrition was associated with larger feeding intolerances and therefore a resulting lack of nutrition. The time of the study was 28 days from the start of the feeding intervention. According to Melnick and Finio-Overholt's hierarchy of evidence, we rated the strength of the article as high. The study had a clearly defined purpose, a high sample size, valid and reliable instruments, and identified limitations. One limitation of the study was that the patients included did not all have the same degrees of burn injuries. These ranged from 50 to 90% of affected total body surface area. The patients were also of varying ages and received different feeding formulas for varying levels of time. The result of the study would have been more accurate if the levels of acuity, patient age, and regimen of care had been more similar. We could use the results of the study to plan interventions for evaluating the effectiveness of feeding for patients with burns, adjustments in formula solutions, and planning transition to oral nutrition.
These are our references.